Thanks everybody for coming today. My name is David DeLillo. I'm chair of the Department of Psychology. I want to welcome you to the RDAR Seminar Series, the first one of this semester. I'm here today to introduce today's speaker, Trey Andrews. Dr. Andrews is an associate professor of clinical psychology here at UNL. He has a joint appointment in the Department of Psychology and also in the Institute of Ethnic Studies. He's been at UNL since 2016 and has co-directed the Minority Health Disparities Initiative since 2020. His research focuses on stress-related inequities and testing ways to improve mental health access, particularly for Latinx populations. Today, he's going to discuss his findings from a project called Mediators of Violence, Exposure, and Substance Use, the MOVES project, which has been funded by the RDAR Center. The overall goal of MOVES is to identify pathways between specific substance use and violence-related factors to better understand the complexities of drug use and to design effective interventions to reduce harms. So with that, I will go ahead and turn things over to Dr. Andrews, and he will present to us. Trey?
All right. Thanks, David. Not every day you get to be introduced by your chair, so I definitely appreciate that and the summary. So I won't repeat too much of what David said, but just before we dive in too much, I do want to say I normally have a pretty interactive presentation style. I know sometimes that's hard via Zoom. I will do what I can to monitor some of the Q&A in the chat. No guarantees. I know Devin will also help with that, but please feel free to drop those as I go along here. As you can kind of see from the title, what I'm going to be talking about today are very preliminary results, or I should say sort of hot off the presses. This is the first time I've presented on this project and actual results. So you all will be learning some of the things that not even people who worked on the project know yet, because they've just been wrapping these up this week, and look forward to disseminating these more down the road. So let's start a little bit with talking about violence, exposure, and substance use. This might seem fairly obvious to some folks, and maybe some folks are already familiar with this literature, but violence exposure in particular really increases the risk for substance use disorders, and violence exposure may more than double that risk, whereas PTSD, a common mental health concern that occurs after violence exposure, may more than quintuple or multiply that risk by more than 5 times. So there's a really strong relationship between violence exposure, related mental health outcomes, and substance use. In order to explain some of these linkages, both in terms of how violence exposure may put people at risk for initially developing a substance use disorder, but also how violence exposure and related processes might maintain that substance use disorder. There's a common set of hypotheses called the stress coping hypotheses. I'll refer to these multiple times throughout the presentation, and a lot of what I'm going to go through really hinges on this idea of stress coping. And essentially the notion is that really that substance use helps alleviate that negative affect, those negative feelings, that stress, that emotional stress that we experience. And then there are some related hypotheses for how craving might work. So craving could be considered this appetitive state of wanting a drug, although some folks, and this is where my project sort of comes in, may conceptualize this also as a somewhat aversive state, that folks are looking to reduce their craving and get rid of their craving. And in that way, it may function somewhat like that stress coping or negative affect. And not surprisingly, potentially for that reason, those two factors tend to be fairly linked. The negative affect or negative emotionality and craving, substance use craving. So, when we think about that hypothesis, there are all kinds of common ways that we're exposed to this exact idea about how stress coping works. Probably the most common one that's really pervasive in public media, in our everyday conversations, is the role of alcohol. Certainly, a substance that often gets used in this way, or is thought to be used in this way. My talk won't focus so much on alcohol. It'll focus on other drugs, but nonetheless, a lot of those ideas are pretty similar. And so trauma comes into play with a lot of this because, again, that trauma exposure or violence exposure, violence being a type of traumatic event, is associated with depression, PTSD, emotional regulation difficulties, a variety of mental health outcomes. Those mental health outcomes are then associated with increased overall negative affect. And given the relationship between those two, that may then lead to more craving overall. Much of that is fairly thoroughly discussed and debated within the literature. One of the ways that my project adds to this is really looking at the ways that that violence exposure, prior violence exposure, changes the way negative affect and craving may relate to each other, and ultimately how they may relate to downstream substance use. And one of the ways that they may do that is, at least the thinking goes, that difficulties with stress regulation often occur after traumatic events. Those same difficulties with emotion and stress regulation may really limit, one way of thinking of it is it may limit folks' coping strategies that they have. It may limit the effectiveness of some of those coping strategies. It's a real challenge to sort of be able to manage and bring down those negative emotions, or even tolerate some of those negative emotions. And it's for that reason that we might see a stronger relationship between negative affect and cravings, as well as negative affect and substance use. Okay, so as you heard David allude to, a lot of my work also focuses on racial ethnic disparities, and that's something that's always in the back of my mind as I'm thinking about this, particularly in this context, given that Latinx and African American populations tend to experience greater exposure to violence and a host of other environmental stressors. But for African Americans, we often see lower substance use relative to non-Latinx white folks. For Latinx folks, the rates are fairly similar. It varies by substance, and of course, there's lots of nuance within that. But in general, that's kind of what we see. So for at least for me, this is a finding that makes me question whether some of these processes are operating the same way, either before a substance use problem develops, or in that sort of what we think of as maintenance, when a substance use disorder or substance use patterns have already started to develop. And one last sort of pitch for why we might want to do this study in this context is nearly all of the studies that are really looking at negative affect, craving, and use come from large metro areas, particularly when we're thinking about the substance of focus for this study, which are cocaine, opioids, and methamphetamines, which are also the substances of focus for the overall RDAR Center. Okay, so for today, these sort of hot off the presses analyses that I'm going to focus on are really those day-to-day predictors of negative affect and craving, or probably better phrase, predictors of day-to-day negative affect and craving. I will note that I won't be able to dive too much into actual use patterns or day-to-day use patterns, mostly because there's just enough of a split in the sample where about half of the sample is using every day, and it really limits some of our ability to do that. in a neat and clean way. So we're still sorting through some of that data, getting that to a place where we can really examine it. So that won't be included in this, but there's still, I think, quite a bit to learn from looking at these day-to-day predictors of negative affect and craving. And also, given that I think some of these kinds of designs that I'll be talking about, I think are relevant for the rest of the center and just relevant in general to think about how do we complete these studies and with the kind of population that we're working with here. So I'm going to talk a fair amount about some of the feasibility and lessons learned, and in large part because this study, like a lot of other of the early career project leader studies, is somewhat intended to really build towards something bigger and be a little bit of a feasibility study. So I'll highlight some of those data as we go along. For those who have heard me talk about this before, there are 3 specific aims that I at least propose to examine within MOVES. I won't bore you with reading them all to you, but you can see that it kind of follows along with what I've been suggesting. That first one really about the ways that violence exposure and stress or emotion dysregulation impact craving and negative affect, and then how those same variables affect the relationship between negative affect, craving, and substance use. And then the last one that's really kind of near and dear to my heart is really looking at some of the racial ethnic disparities, racial ethnic differences across some of these different outcomes. Okay. So we'll cover a decent amount of that, but not quite all of it again, since this is fairly preliminary at this juncture. So getting into the data themselves, these data come from 55 participants recruited from the rural health cohort. That's the RDAR Center's cohort of residents in our area who use cocaine, methamphetamines, or opioids. For this particular study, participants needed to be able to abstain for 24 hours, in part because for some of the tasks that we're going to have them do, it's really critical that they abstain. But also for a lot of folks who might be doing transportation for themselves, it was also a safety concern as well. These folks were all recruited between October of 2020 and May of 2022. And it was definitely a challenge to try to start recruiting in 2020, which is a little bit of why I think it took us as long as it did to get to the number that we got to. And we had proposed to get to 75, so we wound up getting fairly close. But given the pandemic and its effects on not only this project, but I think the center overall, that helps explain a little bit of what happened there. But ultimately, I think given all of those challenges, I'm pretty excited that we have the data that we do. So once we recruited people, we brought them in for a lab visit where and this was on the UNL campus, where they completed a urine drug screening, the Trier social stress task. During that task, actually before, during, and after, we took salivary samples of stress hormones, and then that same day, right after that task, they completed a series of questionnaires. I'll dive into what those questionnaires focused on here in a second. Once they finished the lab procedures, they then transitioned to the EMA, what we call an EMA, or ecological momentary assessment portion. And what that is basically participants 4 times a day got sent Qualtrics mobile survey links that we sent out by text. And we actually did that for 5 weeks, so quite a while. And I'll pause here to really highlight that one of the things that we were trying to do to highlight some of those novel pieces of the way that violence exposure and stress or emotion regulation may contribute to these patterns of substance use was link together these fairly rigorous tests of those factors in the lab with EMA. Now, each one of those separately, the lab-based portion, the EMA portion, have been done to some extent, but really combining those two has been relatively novel, particularly in this kind of sample, where we're looking at community residents, all adults, and a sample like that who are using cocaine, methamphetamines, or opioids. All right. So a bit more about that stress task and questionnaires. I will say I'm presenting most of this as a bit of background so folks understand. Somewhat like the substance use data, we're still working through some of the cortisol data and getting those prepped. And so I won't focus on that as much. This time it's also, as you'll see, there's enough to go through with all of the other pieces that maybe that's another talk for another time. But in any case, you can kind of see that protocol. And for the most part for today, I just want folks to understand and to be transparent about the fact that that packet of questionnaires that I said they're completing, that's really happening after about 90 minutes of this protocol, which I think is something that I would have wanted to consider a little bit more, but I'll talk feasibility a bit more later on. Okay, so those questionnaires that I mentioned, once they get done with all of that stress task, they then, like I said, fill out those questionnaires, which include, among other things, a measure of trauma, or what is often called polyvictimization in this case. And at least that's how I'm going to approach it for this presentation. And all that really means is that I'm taking the sum total of different types of traumatic events that somebody has experienced and pulling those from a measure called the Trauma History Questionnaire that assesses, this modified version that I'm using assesses 26 different types of traumatic events. So it really gives a good measure of the multiple different ways that somebody might have been exposed to different kinds of traumatic events, with a heavy emphasis on violence. We also assess baseline substance use, which we use with the Phoenix toolkit. And the primary measure I'm pulling from that is just baseline substance use frequency, or what we might think of as, I might call past 6 month frequency. And that's averaged across their preferred substance, whether methamphetamines, opioids, or cocaine. For mental health, I'm going to kind of skip around a little bit here. We also examine depression and PTSD using some pretty standard measures, what's called the PCL for PTSD, and then the Patient Health Questionnaire, PHQ, for depression. And I'll stick for a second on depression and make sure I highlight sort of these symptom severities, these ranges, and note that anything 5 to 9 is considered a symptomatic, sort of a clinically elevated range, maybe not super severe, but still clinically elevated, and then 10 plus gets at moderate. And as we'll see as we go along, the folks who are participating in this are really falling pretty high on this measure relative to a lot of other community samples. Before we get into that, after they complete all of that, again, they have these mobile phone questionnaires that they complete. And we designed this protocol to be almost identical to a protocol that was already done with a similar population, a population of different populations of folks who had been using either methamphetamines or opioids, heroin specifically. And so as we go through this, you will notice that I think this is a fairly burdensome approach, if I'm being just fully honest and transparent. But I will reiterate that a lot of that really is based on things that have already been done and that had been established as fairly feasible within the research literature. So with that caveat, they were sent these surveys 4 times a day. Participants got to select when they received it. It roughly corresponded to morning, midday, afternoon, and evening, roundabout. And then each of those had to be spaced at least 4 hours apart. They all assessed craving, planned use, and negative affect. Once per day in the morning, we would ask if they had used any substances in the last 24 hours, and they just picked from like a drop-down list of have you used any of the following, fairly simple and straightforward measure there. And then they received some follow-up questions about, if so, when did you use, what, how much did you use, and things of that nature. And then once per week, at the end of every week, they got a measure about past week violence exposure, and these were just, I believe, 7 items taken from the trauma history questionnaire that focused on what we anticipated would be kinds of traumatic events that could recur, or that participants might experience over that little over a month, those 5 weeks worth of completing these. The research staff reviewed these completion rates, both to provide compensation for participants, but also to problem solve any issues that arose every week for each participant. So there's a heavy amount of staff involvement in making sure that this is happening and correctly, and that we're working well with participants. So in that way, it is fairly time intensive. I won't spend too much time on this, but this just is sort of a way of visualizing what a typical week would look like, and all of the different measures that they're getting. So NA is the measure of negative affect, which those come from 10 items from the positive and negative affect schedule. Craving, planned use, so P stands for actual use, and then we also assessed sleep. But yeah, so you can look over that table and really get a sense for how much they're completing. And what I would, looking back on this, I think one of the lessons that I would take was these latter ones throughout the day, they aren't too burdensome. It's a total of 16 items. It took participants between 2 and 5 minutes to complete these. So these were really quick. These others still weren't that long. It started taking participants between 5 and 10 minutes to complete these, even the longer ones that they completed at the end of the week that had those measures of violence exposure. So it's still not a ton of time, but added up, especially over the period of several weeks. I do think that is some significant burden. I want to recognize both that as we talk about the quality of data, but just the appreciation that I have for the participants and how many folks were really willing to sign up to do this and answer so many questions so often. Okay, so in diving into a little bit of background about the sample, we can see it's largely it's an adult sample with a mean age of about 48. So community adults for sure. And if you remember, I said to keep in mind those ranges for symptom severity for depression. You can see that the average, just the mean level of depression symptoms is 9.18, which starts to get it close to that moderate range. And for clarification, there are samples of participants I work with where we're doing a treatment for PTSD where the depression symptoms aren't averaging this high. So as we go through this, I think that's something that really stands out and something to note. The other thing that I would probably point out here, one of the other things is this trauma polyvictimization. And again, this is really quite high for a mean number of traumatic event types. In other samples that I've collected, other data that are out there, this would be for sure at the higher end of the polyvictimization in a sample. You can see that for Lincoln, this is a relatively diverse sample racially, ethnically, and primarily we're looking at the participants of color, those folks primarily identifying as Black or African American. And then I'll also note, helpful for context as we go through this, very few people are currently in substance use treatment. And bolding, just highlighting the two of the things that I noted before. Okay. With some of that background out of the way, I want to talk and really go through some of the feasibility here. I'm going to highlight the missing data for craving, because craving is one of the first measures they complete. It's really kind of in some ways, the canary in the coal mine for if people aren't completing that, then things are going kind of sideways. And I'll note here that at least in the samples this is based off of, the protocols it was based off of, it's often that roughly 70% of participants complete roughly 70% or more of the of all of these EMA measures. And we weren't too far from that. I think we had a little bit lower completion rate than we would have hoped, in part because we did have a couple of participants, at least two that we know of, who had issues with just the software. And that's a relatively gentle way of saying that cell phones started treating our text as spam, and we had to try to figure out ways around that and to give participants reminders. And that became a pretty significant challenge. And one of the things that we've also given Qualtrics some feedback about, and I know we're not alone in that, but that becomes really problematic that these start going to spam, which is another sort of practical consideration potentially about sending so many of these messages. So I think it may have had something to do with just the sheer volume of texts that we're sending and that participants aren't expected to reply to. Could be wrong on that, but that's sort of one of my working hypotheses here. Still, looking overall, what I would say is people are still completing most of these measures, but that really varies across participants. As you can see, this chart is a histogram or frequency diagram of how many people are missing what percentage of data. So you can see the largest number of folks here are missing 10% or less, and that really stands out. And then we kind of have this trailing off, but we still have a large chunk of people who are completing 30% or less of the measures. Of course, so that translates to 11 people who are missing that 70% or more. And then 2 of those seem to be those folks who are having some issues, software issues, spam issues with their phone. Okay. One of the things that I was interested in, especially in thinking about what are the takeaways for how to do a project like this. I realize I haven't even gotten into what are the other findings, but I do think for many of us in this area, understanding how to maybe combine these pieces that I'm trying to do here is really important. So I'm looking at, in this instance, predictors of whether or not participants completed each measure. For stats folks out there, I'm using some multi-level models with some binomial regression here. And what we find are the two primary things that I think are noteworthy about the feasibility of this is somewhat to my surprise, the survey length didn't seem to have a really large effect on whether or not people completed it. But probably less surprisingly, the farther along people got in the study, the more likely they were to start missing some of those assessments. So as we get into week 5, you can see that we're now starting to miss about half of all of those. But in week 1, it's looking pretty good. We're getting folks to complete about 70% of the assessments that we're sending out. That missingness, I'll note, is not associated with virtually any other factor that we're looking at here. So I was somewhat anticipating that missingness might be really associated with like substance use frequency or some mental health outcomes, and that's really not the case. It's not associated with any other demographic factors either, at least in these data. So the main one here really is that it's that overall duration of the study, how many weeks they're having to complete these measures, which I think becomes an important takeaway for potentially how to do this a little bit differently. Nonetheless, given what we were able to obtain, we still got some, I think, really interesting and important findings here. Before I go on, I see I got a quick question about if there are other recommendations, or if Qualtrics is something I would recommend for others if they wanted to venture into EMA. I think the short answer is maybe, but I'd explore other options. There are a shameless plug here for RDAR software. We have things like the Odin application that was built. Really, the building of that was led by Bilal Khan, one of our sort of key affiliate members here. And with that kind of app, you don't have to worry about, is the phone going to start treating my my survey links as spam? And so I think there's that. And as I'll talk about in a second, I think one of the other lessons is if you're going to use something like Qualtrics, that it's probably better to reduce the frequency with which we're doing some of the assessment and potentially some of the duration. And I think those are pretty critical takeaways. So Qualtrics wasn't terrible. It was still fairly easy to set up and work with. There just may be some other approaches to consider. And then I would also recommend potentially looking into other software. Okay. So on to some of the other findings here. Looking at data from sort of that baseline in-lab, in-person survey, again, we have some really notable data for the just sheer amount of violence exposure that these folks were exposed to. One of the more significant ones being sexual assault. So you can see that 31.4%, or almost a third of our participants, had reported a sexual assault. But this varies massively by gender. With cisgender women, a majority of cisgender women reporting that they had experienced sexual assault, and a pretty small minority of men. And then the one participant we did have who identified as transgender did also endorse sexual assault. So there's a pretty substantial gender discrepancy there, which will become relevant as we start thinking about predictors of these different outcomes that we're going to talk about, and just what that winds up meaning is that there's a really solid overlap between gender and our predictors that assess for gender and the sexual assault. So as a preview, I don't include sexual assault as a predictor in later models, in part because of the split and because I have another measure of trauma that's in there. Okay, beyond that, as I mentioned, we had sort of modified the THQ and incorporated some other things, one of which was an assessment of overdose exposure. And perhaps really unfortunate but not surprising, there's a lot of really notable exposure to overdose, including almost a little over a fifth of our sample had experienced an overdose themselves. And then I would point out that almost 60% of our sample actually knew someone who had died from an overdose. So I don't, this isn't always really captured in assessments of traumatic events. And I just want to highlight that here, because I think by just about any definition of a traumatic event, this kind of overdose exposure would absolutely qualify. And so as we're going through this, I want to be mindful of that fact as well, that the sorts of traumatic events that they might be exposed to could be different from what we're seeing in other community samples. In terms of ongoing violence exposure, there's really, I was expecting some ongoing violence exposure, some additional exposure to, so that while the study was going on, those 5 weeks that they're completing those surveys on their phone. And this is probably a bit more than I would have anticipated. So 7 participants, or not 7 participants, I'm sorry, these are 7 instances of witnessing violence. And then you can kind of read through to see all of the different types of violence that people were exposed to during the course of this study. And I will note that what jumped out quite a bit from looking at these data is that most of this violence exposure doesn't really revolve around drugs per se, or seeking substances or anything like that. And we can see there, as we go through those data, only 1 instance of physical assault happened while somebody was trying to procure drugs, or while they were using and so on. So that's a prominent factor, but most of these are occurring outside of that context. So I got the question about how was sexual assault assessed. So again, these are all measures from the trauma history questionnaire. I can't remember off the top of my head if it's 3 or 4 items that ask about different types of sexual assault and ask if they've experienced that within their lifetime, and then has some follow-up questions about those, about what age they experienced it, and so on. And then I use a modified version of those questions for this ongoing assessment that we send out to their cell phones. Okay, so getting more into the meat of these results and looking at predictors of craving. These are results from a series of multi-level models, where what I'm doing is I'm looking at predictors of sort of moment-to-moment craving, and I'm using lagged predictors of negative affect and craving. What that means is that if we're trying to predict, say, craving at the second time that they completed it, I'm using the values from the first time they completed it, the values of negative affect and craving, to predict that second instance. And it would be the same for using values from the second time they complete these measures to predict craving at the third time they completed it, and so on. And this more or less averages over all of those different measurement occasions, all 140 that participants are completing. So it's really a way of looking at how much do negative affect and craving at one time point predict craving at the next time point. And so this is a what's called a cross-lagged and auto-regressive model. For those who might be interested. And in this case, what we see is negative affect does have a significant and positive association with downstream craving. It's not the biggest effect. In fact, I was kind of surprised by how small it was, but it is significant. So we are mirroring prior literature there. One of the things that I would also note, still sticking in this left-hand column here about predicting craving, that was somewhat of a surprise to me is even after controlling for some other factors related to negative affect and that sort of moment-to-moment affect, we still see that that baseline depression measure is predicting craving in the way that these work. Everything in the between columns, this is really looking at how those predictors are associated with sort of the overall level of craving, more or less. So the more depression symptoms people are endorsing, the more often they're endorsing high levels of craving. And then probably not surprisingly, the more people are endorsing having used in the last 6 months at that baseline measure, the more often they're reporting craving there as well. So largely what we expected to find, that depression finding me a little bit surprising. But what I do next is really looking at predictors of how strong that relationship is between negative affect and craving. And so I'll start with polyvictimization and use that as an example. As you can see kind of down here at the bottom right, what this means is that for folks with more trauma exposure, that effect of negative affect on craving is stronger than it is for people with less violence exposure. And then we actually see a similar finding for race ethnicity, where the effect appeared stronger among non-Latinx white folks in the sample, which was a little bit surprising, but I think to some extent fits some of those data I shared at the very beginning and may help explain some of those findings. Next, we look at craving, and there's some potentially good reasons to want to look at we looked at, I messed that up. We're looking at predictors of negative affect, and here there's some potentially good reasons to look at also craving as a predictor of negative affect. I won't spend as much time on that, though. I'm happy to answer more questions about why I did that for this model. But what we'll focus on a bit more are these predictors down here of sort of this overall negative affect, and what sort of predicts a higher level of negative affect. And kind of as I anticipated, those depression symptoms are associated with higher levels of negative affect. That makes sense. This DERS, what it says right here is that's the emotion regulation measure, and that's also associated with higher levels of negative affect, which is roughly what we had expected. It was still a little bit of a surprise that, as you'll see, polyvictimization does not predict overall negative affect, and that's a little bit different from what we maybe otherwise expect to find. Then again, we're controlling for the effects of depression, so perhaps there's some multi collinearity going on there, but let's more for us to explore as we go along. As you can see, there's tons and tons of stuff for us to get through. Just some other quick findings that didn't fit quite as neatly in that table. So even though the effect of negative affect on craving was stronger among white participants, I'm at least able to examine this and what we call probe that effect across white and Black participants, and it's still significant across both. It's just a little bit weaker among Black participants than it is among white participants. Also, I think notable is that the sort of two kinds of measures of the correlation of within race. If you remember, all of those prior relationships between negative affect and craving were negative affect at one time predicting craving at a later time. But as we look at the correlations within the same time frame, the same measurement period, those are also correlated positively and significantly, and both in the way I just described, in that overall within each time point, as well as if we look at between participants. So that would mean participants with higher negative affect are more likely to also have or be reporting higher levels of craving throughout the duration of the study. Okay, so I've gone through a fair amount here, and I'll take a step back and just give some key take-home messages that I think are fairly critical. And one that even before we discuss what the findings are, I just want to reiterate that there's some pretty significant amounts of trauma exposure in this population, and particularly different types of violence exposure, much higher than we often see in community samples, including samples where folks are experiencing significant symptoms of PTSD. And so I think that when we talk about the effects of trauma, or even the relationships between negative affect and craving, that's sort of something going on in the background that we probably need to be aware of, and may also be part of the reason why we see such high depression symptoms in this sample as well. Within this, one of the surprising things that I mentioned was that polyvictimization didn't appear to be associated with overall levels of negative affect or craving, but what it did do was increase the extent to which negative affect seemed to lead to craving. So that relationship between negative affect and craving will seem stronger for those with more trauma exposure versus those without. And I think that is one of the more important takeaways here, in part because that suggests that it's not just about violence exposure leading to negative affect, leading to craving, leading to substance use. So that sort of sequential pattern isn't really what follows, at least in this sample, again, where we already have folks who are experiencing a fair amount of traumatic events. It's that it's solidifying the extent to which that negative affect may lead to craving, or said differently, it may enhance that stress coping phenomenon. And relatedly, that was really the role that we had hypothesized that emotion regulation was going to play, but it didn't, or at least not when we're also considering polyvictimization here. That didn't fulfill that kind of role, and it was polyvictimization instead. And then as we think about the stress coping hypotheses that I mentioned, that generally is supported here. It may not be the largest effect, but we do see that negative affect is predicting subsequent cravings, where people are, at least we might interpret this as meaning that people are wanting to use more as a means of coping with that negative affect. Even though we haven't been able to look at use all of the way quite yet, we still have that that effect where it's leading to that desire to use. And I'll apologize, I need to plug in my laptop here, so I will try to talk through this. Again, I apologize for potentially disappearing from the screen here for a second. But in any case, as I mentioned before, the emotion regulation was really a key piece of what we had hypothesized for that stress coping hypothesis, and it didn't really function exactly the way that that we had anticipated. It did lead to greater, or was associated with higher degrees of negative affect, and we might surmise that there's a mediation relationship going on there, but it's not changing that relationship between negative affect and craving, or not enhancing at least that desire for using substances as a stress coping mechanism. And then this I think I've largely covered here. Those are the two sort of, if I were to distill it down to 2 points, these would be those. And as we think about sort of main takeaways, again, we see the importance of trauma exposure, of these stress coping effects. They happen not just by increasing negative affect. And then taking perhaps a bit of a step back, I think there are a number of sort of feasibility takeaways, or even just practical considerations about how to design these while minimizing participant burden, which we weren't really able to know in advance. Now that we have these data, we can make these changes. But I think one of the things that I would really take away from some of this is that we can probably do with fewer weeks of mobile surveys. We have enough measurements across something like 3 or 4 weeks that we could probably limit it to that. Maybe even fewer per day, and maybe that helps with alleviating some of the extent to which we're seeing participants drop off as weeks go on. If we're only doing 2 or 3 per day, maybe they stick in it a bit longer. One thing I didn't get to mention a ton, I've only briefly mentioned it as I'm talking about some of the challenges with measuring and really trying to predict some of the day-to-day substance use outcomes, is I think for a study like this, there are really 2 directions to go. One, given what we're doing and how much we really need people to be able to abstain so they're going through the stress task while actively under the influences, for something like that, it's probably more helpful to screen more stringently for use, and to be using potentially some of the daily use measures as a way of screening out folks who aren't already using every day, because from just a practical standpoint, that makes it harder. And even theoretically, it maybe doesn't make quite as much sense to be thinking about how does negative affect within a day potentially predict substance use that later that same day, because they're using every day as it is. So that prediction of negative affect or craving to use, maybe it may not be quite the same. And so I think if done that way, need to screen a bit more stringently for use, so that we're really thinking about these effects among a population where it makes the most sense, and then ultimately thinking about it as not just whether they use that day, but kind of the timing and how quickly they may use, or things of that nature. And so maybe doing, if using with a population, or if doing this with a population that's using every day, maybe assessing a bit more thoroughly about the timing and when they're using. There's some other practicality concerns about that may be also challenging, but I think some of that's probably feasible. And then not related to anything I've covered so far, but one of the other take-home messages for me that I do want to mention is, as I said, we did this study on UNL campus, and I genuinely think that was a pretty substantial barrier for a lot of people for transportation reasons, mobility reasons, locating us. This campus can be fairly hard to navigate. So I'm very grateful that the RDAR Center is recruiting RHC folks in an off-campus field office. And I would think, if I were to do this over again, and in some ways I kind of am doing a related project now, I would be trying to take it off campus as well to facilitate people being able to come in a bit more easily. So where does this all lead? So I think one of the things that we're going to be doing next is trying to make sure we can better incorporate substance use and cortisol data. There are just some nuances to how we'll need to go about some of those analyses and data coding that'll be a little bit more complex, but for sure doable. And those are the next phases for what I'll do with these results. And then for my personal research, I think this has been extremely helpful in helping me refine some of the questions that I'm asking in terms of how physiological stress, how stress regulation is really impacted by trauma inequalities, stress inequalities. And so the project that I'm working on currently really incorporates quite a bit more of that. And then sort of a secondary line that's stemming from this is that I think are really highlighted by these data are the importance of trying to reduce or even prevent some of those effects of trauma that may lead to these patterns of substance use. And so there's a few things more longer range but are in the works to try to address some of that. Okay, we've reached the end, so thank you all for bearing with me for this almost hour here that I've been blabbering on. But I want to thank all of the team members. I'm now realizing I actually left one of them off, so I'll go ahead and acknowledge her. Elizabeth Otto, who's now in a PhD program at Texas A&M and has gone on to bigger and better things. She was really pivotal in helping run this, as well as the folks that you see listed here. So Laura Costa, Natalia, Vanessa, Sara, Maria Lee, all team members who helped either get this off the ground or run participants. As mentioned, this was funded as a sort of subcomponent of the RDAR Center and funded by NIGMS. Obviously, the views here don't necessarily reflect those of the funder. But with that, I will wrap up and open it up for any other questions that folks may have that I haven't answered yet.